One reason is that we want to be on time, but we're also cognizant that one of our two speakers is joining us from England, which is 5 hours ahead of us, so it's quite late there, so we want to be respectful of his time. So welcome to our April Java Cafe. And planning the Java Cafes in for the spring, one of the things that we were interested in doing was looking at the impact of the funding cuts to both the UN and as a result of the complete demise of USAID on various areas of the Sustainable Development Goals that GLUNA is very much focused on. Last month, we had three wonderful panelists who were all had a relationship with USAID and no longer do, obviously. And they talked about how what the impact was on the types of projects that they were working on in Africa, Asia, and in Brazil on the type of work that they were doing. And so we wanted to continue this month. In 2 months, Alan here, who's recently back from England, is going to be organizing one that focuses on the impact on the cuts to the UN peacekeeping. Thank you, Ron. Peacekeeping and on initiatives around the world. And so tonight we're going to be looking at the impact on global health. We have two wonderful speakers that I'm going to introduce in a minute to you, but I wanted to highlight the connection with the Sustainable Development Goals. So if you can go to the next slide, please, Patsy. As we indicated, we have tried in our Java Cafes as much as possible and our other GLUNA programming to tie it into the Sustainable Development Goal. So particular tonight, we're going to look what's going to be discussed tonight. We'll focus on the next slide. Primarily on goal 3, which is good health and well-being, but also other goals, because health is closely related to a number of other goals. In fact, probably all of the goals, but I wanted to highlight a couple more. If you go to the next slide, please. No poverty, 1, 0 hunger, quality education, and gender inequality. Those in particular, but others as well. Because if the decline in global health is going to impact all of these, and of course, all of these impact global health if those goals are not being met either. So all of this is going to be covered indirectly, if not directly. Oh yes, and 6, clean water and sanitation. The next slide. Yeah. Okay. Before I introduce Alan, I wanted to bring this to. Many of you know, I was associated for 30-some years, primarily with the African Studies Center, but also with the College of Education. And I taught courses both at the undergraduate and graduate level related to education in Africa, but more broadly, tying it into the global South as well. One of the things that I had the privilege of doing during this period of 30-some years was to lead study abroad programs in Africa. First in Zimbabwe and then in South Africa after the year 2000, when it became politically untenable to take students into Zimbabwe. The focus of the program that Ann Schneller and myself started in Zimbabwe, and we kept this name, was Education, Society, and Learning in Southern Africa, Zimbabwe, South Africa. We did this in the 1990s and unto the 2000s. The last year that I did it was 2017. The beginning years was the height of the HIV pandemic in Southern Africa. And this topic of the focus that Alan will be dealing with is deeply entrenched in my own experience. I can vividly remember going into rural primary, elementary, and secondary schools. First in Zimbabwe in the late 1990s, and then in South Africa between 2000 and 2010-11, when ARVs became available. It was dramatic for the students. They would go into the classroom, they were told by the headmistress or the headmaster that in that school, in that rural school, primary or secondary school, that between a third and a half of the teachers that had been assigned that school were either very too ill to teach or had already died. And what was very, very impactful for the students was when the teachers told them that look in this classroom, there are about a third of the kids in this classroom are at 10 years of age or 11 years of age are heads of household. In other words, their parents had died or were very too ill. They were the only ones left to take care of their younger siblings. So this was something that had a dramatic impact. And I remember we'd have debriefs, no matter where we went, and it wasn't just HIV at the end of each day. And I remember at one particular time when going into a school when we were confronted with this, that one of the students said, you know, John, this is amazing. I sat there after they told me, and when he said 1 in 5 of these students is going to be dead in the next 2 years. And he said, I went around and I counted 1, 2, 3, 4, 5. Which one do you think of those 5 are going to? And this was real. Then fast forward to 2017, 2018, the last years I went to South Africa, visiting the very same types of schools. HIV AIDS was still in the mix, but it wasn't dominant at all. You didn't see sick kids. You didn't hear about absentees of teacher absentee because of illness or death. And that's in large part because of the availability of ARVs, which in large part is due to international organizations and our own government through the PEPFAR program, providing the money both for the vaccines, but also in addition to that, for the distribution and for the action at the clinics and throughout rural Africa. So it really has an impact on the students that I had the privilege to talk, and an impact on me as well. So even though I have no background in the medical arena, but let me introduce briefly Alan. Sorry, I didn't want to take up that much time, but it's really a poignant issue for me. My first introduction to Alan is not through Ron, who mentioned him a couple months ago in our planning session. My first introduction was that Alan was the founding director of the health of, oh goodness, I have this in my notes. The health, help me out, Alan, the health
economics and HIV.
And HIV at the University of KwaZulu-Natal, which, by the way, was the first university that MSU had a linkage in through the university. Part of the merged university of KwaZulu-Natal was the University of Durban, Westville, which was the very first linkage that we had in South Africa post-apartheid. Alan was very gracious when I approached him, and he did not know me. I was given his contact number from other people and asked him, I said, I have students here. They're primarily teacher education students who will be teaching in the US over then hopefully for the next 30, 40 years of their lives. We're doing an educational study abroad in South Africa. HIV is such an important issue. We know that your research institute, among many other things, looks at the impact of HIV on schools. And he was very gracious. And for, I think, over a period of the last 10 years that I ran the program, every year we did a full day program on their beautiful campus, and all provided through the graciousness of Alan, who is by training a health economist. He's currently in England. He has many things, many honors to his credit. But I guess the most important one in terms of, he also has an OBE, an Order of the British Empire, in his name, in recognition not just of his fellow academics, but in recognitions of the United Kingdom, but also the larger British Commonwealth, of the work that he has done in HIV/AIDS. And so he's going to be talking from the perspective, as he has on his title there, Forgotten but Not Gone, HIV/AIDS in Africa. Thank you very much, Alan, for joining us at midnight or whatever time it is in England now. And we look forward to your presentation. So Alan is going to go first. And because of the time differential, we'll take, unlike what we normally do, we're going to take time to have questions and discussions after his presentation, and then we'll go on to our esteemed colleague, Dave.
Can you ask him to prompt me to?
Oh, yes. Alan, will you prompt Hassan when you want the slides to be moved forward?
Yes, that would be absolutely fine. Can you hear me?
Very well, thank you.
Good.
Can
Okay.
everybody hear me?
Yeah.
So the prompt will be next slide, please. So can I have the next slide, please? So I thought to myself, I'm going to begin with 3 slightly tangential slides. And I thought to myself, well, what keeps us up at night? And those are the things which I think keep us up at night. And the important thing about this is that if I look back 30 years, the world seemed very hopeful. The Iron Curtain had fallen, South Africa had transitioned, poverty rates were falling, life expectancy was rising. But at that moment in time, HIV and AIDS was a global issue. Today, it doesn't even make it into the top 10. Next slide, please. So I love this quote from George Orwell because I think it really places us in context. This is important to remember. We are, and I think we're a lot of grey heads in the room. So we are the past, but we control the present. And I think it's really important that we have a legacy that we can pass over. And that's why I was willing to stay up until midnight just to share some of the facts and ideas from an area where I have access, where I have expertise. Next slide, please. And it's also important for me to make put in context the reason I do this. And that's because I went to this amazing school in Swaziland, Waterford Kamhlaba, which was a co-educational, multiracial, multi-faith establishment set up by a group of idealists back in 1963, and it made me. So let's move on to the next slide and remind ourselves what we're talking about. AIDS is caused by a virus, the HIV virus. It was first identified in New York, San Francisco, and a few European studies in 1981, and nobody knew what it was. But by 1983, the virus had been identified, and we were rapidly getting to grips with it. The science showed us, first of all, that it's a zoonotic disease. It's something that's spread from animals into humans. It's not the first, and it won't be the last. Indeed, since HIV spread into humans, we've seen, just to mention 3, Zika, monkeypox, and COVID. It's a retrovirus, and that's important because they're really hard to deal with. It's transmitted through blood and body fluids. It's not easily transmissible. So sex is the most common mode of transmission, but even then, it's not that easy for it to be transmitted. Thank God. If this was a COVID-type disease spread through sexual intercourse, the world would be in deep, deep trouble. And there are non-medical interventions that work. And that's something of a problem because it means that the medics are not always willing to relinquish control of it. From 1983 to 1996, we just watched people dying. There was nothing you could do. There were some therapies which were tried and they did keep people alive, but for a very limited time. In 1996, antiretroviral therapy, ART, you'll have heard of this before, was introduced. And that was the idea was that you combined 3 drugs, but it was eye-wateringly expensive. And basically, the cost in those early years was $10,000 per patient per year. Obviously, something which was well beyond the reach of all of the developing world. Now, in the 2000s, thanks to a great deal of activism, and I must pay tribute to the activists who really fought for this, prices started falling rapidly, and there were initiatives to make treatment available around the developing world. We don't have it, and I think this is still quite shocking. We don't have a cure and we don't have a vaccine, but we can keep people alive with the drugs at a cost, and we can put in place interventions which will prevent transmission. Very simple interventions: clean needles, condoms, uh, stick to one partner. They're not rocket science. So next slide, please. I'm going to spend just a minute on this because one of the things about the HIV pandemic was that there was an inevitability about it. And if, as I fear might happen, we lose the huge generosity of the American government, it could well come back. Because the first line there is HIV prevalence, which you can see rises, and eventually it will peak and start falling again. People who are HIV positive will, in the absence of treatment, develop AIDS. It's not a there's no way of avoiding this. It is going to happen. If you are HIV positive, then in 8 to 10 years you will develop AIDS, and if you develop AIDS, you will die within 2 or 3 years. And then the last line, which is a really important one because this is a conceptual thing, is the line of impact. And you heard a little bit about that from the introduction. It's the loss of adults who support families, meaning we have child-headed households. It's the increase in orphaning. It's the increase in the number of beds required in hospitals. It's the increase in the number of funerals and cemetery space that you need. Now, the point is that we'd rather not have a blue line there at all. Prevention, an ounce of prevention is worth a pound of cure. If you do have the blue line, you are going to have the AIDS pandemic, which means you are going to have to provide treatment. If you don't provide treatment, then you are going to see impacts. And I guess we could talk about an impact of even providing treatment because it's all a case of trade-offs. If you do this with your money, then there's something else you can't do. And that's, I am afraid to say, one of the things that we're seeing on the news in the UK at the moment, thanks to the mess that is in the Gulf of Hormuz. So I developed this slide 30 years ago, and it's still true. Things have changed. We do have treatment. But do we? Will we? I'm not sure we will in the future because I fear we're going to lose the money. And one of the realities is that African governments don't necessarily see this pandemic in the way that the rest of the world does. And I'll come back to that, or somebody can just remind me to come back to that in the questions. Next slide, please. So there are a number of critical concepts. The first one is the flow, or the first one is flows. And there's a flow of people infected every year. And you can see this with every pandemic. Look at the flu pandemics that hit you every year in the West. There's also a flow of the number of deaths every year. And if you can interrupt those flows, then you can address the pandemic and try and bring it to an end. But then there are also stocks, and there will be stocks of people that we have to deal with. The number of infected people. And once you're infected, you need treatment. So another stock is the number of people on treatment, and that will determine how much money is needed. These are very simple ideas, but they are so critical in understanding and responding to the HIV epidemic. So we just have two goals, really. One is to reduce the number of new infections, and the other is to increase the number of people on treatment. But the problem with that is that they need resources. That needs resources. And it needs not just financial resources, but it needs an emphasis on this as a crisis. And that's why I titled the talk, It's Gone. It's forgotten, but it's not gone. And that's the reality with the pandemic, and it's why it may come back to bite us. Okay, next slide, please. This is one which I think is perhaps one of the most telling pieces of information I saw. It's from about 2003 in Swaziland. I grew up in Swaziland, so the country is very dear to my heart. It's also now called Eswatini, so I must start calling it Eswatini. This shows the HIV prevalence by 5-year age category among males and females in Swaziland in 2003. As you can see, young women saw HIV prevalence rising by 5-year cohort to the point where 49% were infected in the 25 to 29 cohort. Now, that doesn't mean you walk around the room like you were saying earlier and go 1, 2, 3, 4, 5. That means you go around the room and you say 1, 2, 1, 2. And it's actually worse than that because the lifetime chance of being infected goes up to about 60% if you've got those levels of prevalence. And you can see that it starts declining over time. That's largely a function of people having got through the highly sexually active era of teens and 20s, but also dying. I mean, let's be clear on this. If you die, you're no longer included in the HIV prevalence. The other important thing about this slide is you'll notice there's a gap between male and female HIV prevalence, and that is to do with intergenerational mixing. Now, I'm not saying this is a bad thing, but what I am saying is that it's something we need to respond to because the 30 to 40-year-old men are infecting the 15 to 24-year-old women, and that is a real problem. So it requires some changes in modes of thinking. And having gone to Zimbabwe and South Africa, I don't need to tell you very much about the misogyny and the inequality that existed between the genders in that part of the world, which may be a large part of the reason why Swaziland was the worst infected in the world. Okay, next slide, please. Now, the reality is that the world did respond to this. In 1996, UNAIDS was formed. In that point, there was no cure and no vaccines. And you know what? There's still no cure and there's still no vaccines. The treatment was rolled out. I lived through the denialism of the South African president in 2000, where he flatly denied the existence of HIV. That was Thabo Mbeki. And it was an incredibly difficult time for us because we were, I was known as a dissident scientist, which I suppose was a badge of honor, but it was a really tough time because not only were we dealing with a government that was not facing the problem, we were facing it on a daily basis in our lives and among our staff. And I'll never forget going to visit one of my staff in a local mission hospital as he lay there. He's actually still alive, which is amazing. But seeing this face looking up at me with these terrified white eyes and saying, listen, do your best. You've got a job with me if you get through this. When you get through this, I should say, I said. Now, of course, UNAIDS was just the beginning because we needed a major mobilization of resources. And that happened in 2002 and 2003. In 2002, the Global Fund to Fight AIDS and TB was established by the UN and it operates from Geneva. And then in 2003, something quite miraculous happened. The US President's Emergency Plan for AIDS Relief, or as we'll call it from now on, PEPFAR, was established. And that was really quite transformative. And I'll show you some data to show why it was so transformative as we move forward. In 2023, there were about 90 million AIDS cases in the world, and there had been 42 million deaths to date. Sorry, there'd been 90 million cases in the world and 42 million deaths. In 2003, there were and 1.3 million new infections and just over 500,000 deaths. But those numbers were starting to decline. So we were looking at something quite hopeful in the 2023-2024. Go forward to 2025 and the resources are no longer there. Next slide, please. So this shows the trends in adult infection. And as you can see there, and I'm not going to go through the details, just look at the way the line goes. Up to 2024, the number of new infections was going down. It was steadily declining. If you want to look at these slides there, you're welcome to get copies of them. But that shows you that the vast majority of infections were in the heterosexual populations around the world, and that proportion has not significantly changed, I would say. Next slide, please. But this disease is one which is primarily an African disease. Over half the infections are in East and Southern Africa. Another 10% are in West and Central Africa. If we look at the child infections, you can see this is, again, primarily the worst is in Africa, East and Southern and West and Central. The numbers are negligible in Europe and North America. If you look at deaths, negligible in Europe and North America. 380,000 in Africa. That's well over half the deaths. So this is a disease which Europe and North America can afford to forget. I haven't put the Asian figures on there because it would just confuse the slide, and because they're so small that they just don't really feature. So this is a burden that falls primarily on Africa and primarily on East and Southern Africa. And I'm afraid to say the places that I know and love the most, Eswatini and KwaZulu-Natal, are the worst affected in the world. The most proportionately and absolutely people infected in South Africa are in KwaZulu-Natal. Next slide, please. So where are we now? Well, this is a really important slide because the second of those bars shows the resources that come from PEPFAR. And as you can see, the greatest part of the resources in Eastern and Southern Africa, more than half of the resources up to 2024 came from the generosity of the American government, PEPFAR. Next slide, please. So where are we now? Well, it's not at all clear. And one of the reasons it's not clear is because we don't know where we're going. If we see programs being rolled back, we can expect HIV prevalence to rise. If we see treatment being rolled back, we can expect people to die. New infections had declined. Sorry, let me get my tense right here. New infections had declined globally and in Africa. Illnesses were rising. Of course they were, because if you put people on treatment, then the number of AIDS cases will rise. Today, although the number of people on treatment was rising, today, as a result of US cuts, it's probably declining. And we're absolutely certain that donor funding has declined. Next slide, please. So where we are now is that, and I really prepared this talk. I actually did quite a lot of reading to work out exactly where we are because this is no longer my core business. And I have to say, I still don't know exactly where we are. If somebody can tell me, I'd be very, very grateful. But what we saw was that in January, Trump issued an executive order to freeze foreign assistance. In January, the State Department issued a stop work order. In early July, the House approved the rescinding of $7 billion in foreign aid. USAID was disbanded and health programs were cancelled. According to the National Public Radio, PEPFAR escaped the rescission order, but programs are being shut down. So in actual fact, you might as well have rescinded the money because effectively the infrastructure that supported the programs, even if you gave the money now, there's no one there left there to spend it. And people, and I'm afraid to say, the level of trust in the US government has diminished dramatically. I don't think people just don't know where they are. And then in the congressional budget justification for 2026, they said we plan to accelerate transition to recipients and increase international ownership. Well, let me tell you, the surest way to make sure that programs shut down is to make sure that you have no certainty. And that's where we are on the US government. Next slide, please. You know, there's a brilliant article by Princeton Lyman and Stephen Whittles. No good deed goes unpunished. The unintended consequences of Washington's HIV and AIDS programs. And it's true. Because this dependence on America, on the US government, means that we are totally and utterly screwed when it comes to dealing with the HIV AIDS pandemic. Next slide, please. So I'm going to end by showing this slide whilst I read you a quote from the Afrobarometer. And the reason I show this slide is because that is, as we say in Durban, my break. When I venture into the ocean with my pathetic bodyboard, you don't see me standing on boards. That's where I go. For more than 2 decades, now I'm reading from an Afrobarometer document here because they've said it better than I can. For more than 2 decades, USAID served as an operational backbone of the US President's emergency plan for AIDS relief, translating the initiative's strategic vision into clinics, supply chains, community programs, and health service systems infrastructure that sustained much of Africa's HIV response. The loss of USAID introduced profound uncertainty regarding PEPFAR's future and signaled the erosion of the institutional machinery that had underpinned progress in HIV prevention and treatment across the continent. Estimates indicate that 65% of USAID managed PEPFAR awards were terminated or left in limbo. Other donors have not filled the gaps, and development assistance for health is contracting. People are dying as a result of this. Now, you might say African governments should have stepped forward. Well, let me say one of the points that Princeton Lyman made was if people come in and say, you've got a problem and we're going to solve it, that means that governments are never going to pick that up. And if you suddenly take everything away, then you have to battle to recover. South Africa will, but the rest of Africa, God help us. And I don't have a conclusion beyond that. I think this is something that's happening around us. It's something that's happening to us. And to my friends, as you sit there in is it Wisconsin or Minnesota? I forget. Wisconsin, yeah. As you sit there, just know that no man is an island, and we are being terribly hurt by what has happened and is happening. I don't know what you can do. I don't know what we can do. It's a very bleak picture. So that's it, folks.
Okay, as I said, deference to the 5 hour difference, but we're going to take questions and comments at this time. Do I need to carry the microphone around to this?
Yeah, I can pass it around.
Okay.
That's an option.
Okay, so
Can you hear us, Alan?
Alan, can you hear us? Okay.
I can hear you, but do speak into the mic.
Thank you very much for your presentation. I think the way this program USAID and PEPFAR was handled by the administration was very inhumane and all at once, and removing the funding without really caring for the people of Africa at all. Now, that seems to me very clear, but I wanted to ask you about how you'd respond to sort of, let's take the conservative argument. Here we are where Africa becomes very dependent on one source of funding, the United States, for its aid treatment. And so rather than dial that down or seek other funding, we just cut it. And so now you're left with the question, you've mentioned several times, other donors have cut as well. So one of the questions we hear a lot is, well, you know, the other countries, Europe, where's the EU in all of this? Where are the other developed countries that could step into the breach and provide this and create infrastructure? Have they ever had a presence in Africa? Would this be possible? And, you know, that might help weather the storm as we suffer under Donald Trump's administration and what might come after him. So I just wonder why other funders have cut away and whether there might be other sources. I think relying on domestic African countries to say, well, it's your problem, you fix it, isn't realistic. But are there other developed countries that could help fill this breach right now? That's kind of my question.
Okay, I think the key point is that most other countries, no, let me go back a step. I think when America said, this is the problem that we see, we're going to solve it, a lot of people said, okay, there are other things we need to look at. There are other areas where we need to put money, for example, into agriculture and so on. So donors tended to say, okay, this is your area of comparative advantage, and you're taking it on, so we'll go into other places. Now, there was a lot of money going in from the European Union. There was a lot of money going in from DFID. They all had their own AIDS programs. But when the Americans said, we're going to take care of it, we said, thank you very much. And guess what? I think this is happening again in Iran, where you said you're going to take care of it, and the rest of the world is saying, oh, we're not so sure. So I think it's a sort of inevitability that if you can see someone is active in an area, then you're going to say carry on. And we're scrabbling to get back into place, and also not knowing what's going on, because we've had such mixed messages saying, yes, we're pulling out of Africa, but no, we're going to carry on providing drugs, except we've closed the clinics that we're going to distribute them. So it's a very confused and very complicated situation. But at the end of the day, there are people who were getting their drugs courtesy of the generosity of the American people. And remember, it's you people that did it, because you're taxpayers, and they're your tax dollars at work, and now they're not.
No, it's going.
Hi, I really enjoyed your presentation and your speech. So I was wondering, so you said the cut from other donors and kind of sister programs to the United States president, like before the PEPFAR program. So now that the money has been cut, what kind of step or what kind of stand does PEPFAR still have? Like, can they still make a difference? Do they still have any standards, or is it just useless, or can they not do anything anymore? Can they help, or?
Well, sadly, I think PEPFAR's gone because the people who were working in it were, it's been dismantled, and I mean, can the people still make a difference? Yes, they can, but they can't because they haven't got the infrastructure with which to do things. And I think you've got to sort out we've all got to sort out where we fit into this very complicated world that we're living in at the moment. I'm very pessimistic. I'm sorry to say this, and I can't see you on the screen. You sound quite young, so it's a terrible thing to have to say. It's your problem. It's terrible, but it's going to be your problem, and it's yeah. I don't know. I
Do we
have
have
no
one
idea.
or two more
Doesn't mean I'm
questions?
giving up. In fact, I tell you what, Ron, you're somewhere in the audience there, aren't you? Why
Yeah,
don't
he is.
you raise your hand, and when I'm gone, go and talk to him about this, because he's a man of great common sense, is Ron, and he might have some ideas.
Set me up, why don't you?
Yeah,
Some of us
I
might
will.
make
I'll buy you
different-
lunch next time you're in Norwich.
Well, I have a question, final question then. I'm gonna ask you to do the impossible, Alan. Alan, thanks for setting me up. By the way, here's your question. If we are hopefully, we see a turnaround within the next 5 years, or 4 or 5 years in the US, and I really doubt that that the UN funding in general and the humanitarian funding in general will ever be back at the level that it was. But let's say we were to step into the gap and correct some of this. How long would it take to arrive at a workable solution, or do you see any hope there at all? Let's say it's not going to be just the US, it's going to be other countries stepping in as well.
I don't think it would take that long. And I think that this is in our hands. It's in our hands, Ron, and you and me and the audience here, is you have to keep the flame burning. You have to keep the hope alive, and you have to reach out to the younger people in our community and say, we have we have a responsibility, and we have an international responsibility. And then I think it can happen fairly quickly. But I tell you what, we're going to have to work at getting trust back from the people we went out to help. There's been a lot of trust and belief lost over the last little while, I'm afraid. I think we can do it. I remain an optimist, and I guess I'm a bit like Tigger in Winnie the Pooh. You know, I keep bouncing.
Okay, thank you very, very much again, Alan. And please, if you're up to it, if you have another cup of coffee there, we could teleport some over to you. We have some good coffee here, but we understand if you need to leave us at this time. But thanks so very, very much. We would appreciate it.
Thank you very much. I am going to leave, but I think you need to understand that the reason I stayed up to do this is because I believe in what your organization are doing in terms of keeping some level of sanity in this horrible world that we're living in. So thank you for inviting me, and good luck and goodbye.
Thank you. Okay, I'm gonna do something I don't normally do, and I'm gonna read a little thing. I didn't know that I honestly, I can say I don't know if I knew anybody that had a Wikipedia page, but I decided, how am I gonna introduce Dave? I've known Dave for 40 years now. I had the privilege of working for him directly with him for about 25, 26 of those 40 years. What do you say? How do you introduce him? And somebody that you also have deepest respect for. So I said, I wonder if he has a Wikipedia page, and I went out and I looked, and so there's, and on like some Wikipedia pages, it's quite brief, but it does summarize things. I mean, I'll start out with something very personal. I would not be standing here today, quite literally, if it weren't for Dave, because Dave was the one who hired me. 1987, so that's 39 years ago, Dave. Thank you very, very much. Thank you. I wouldn't have been here, and so that's a personal connection. But let me just read, because this two paragraphs sort of gives the summary of the précis version of the last 90 years, or at least the professional part of the last 90 years. Dave Wiley worked on race relationships in Zimbabwe between 1961 and 63, and then conducted research on the sociology of urban and rural environments in Zambia, Kenya, and South Africa from 1968 to 2010. From 1968 to 1976, he was on the sociology faculty at the University of Wisconsin and director of the African Studies program there. And he came to MSU in 77, and he remained as director of the African Studies Center and professor of sociology, and he remained as director of the African Studies Center to 2011, and then was the acting chair of the sociology department. He was president of the African Studies Association, which for us as Africanists, no matter what discipline, is our main academic organization. And in the year 1993, but he was vice president of the U.S. National Commission on UNESCO, co-chair and co-founder of the Council of National Title VI Centers. Title VI centers are the centers for all of the area studies, not just Africa, that were federally funded to, like USAID, got cut last year. Lost my place here now. He chaired the international committees of the National Science Foundation, American Association for the Advancement of Science, the American Sociological Association. He was a Fulbright Senior Research Scholar in 1994-95 at the University of Durban-Westville, which was referenced with Alan. After 2000, his research has been concerned primarily with environmental issues in South Africa, militarization in Africa, and international education at US universities. To honor his work, the African Studies Association just this last year awarded him the Distinguished Africanist Award. And what this doesn't cover, whoever wrote it for you, Dave, was your passion about health issues as well, particularly your work for the last 4 or 5 years on inaccessibility and inequity in terms of vaccine availability, not just because of US policy, but because of the policies of the pharmaceutical. And Dave, of course, has been, I don't know, a board member here at Luna for many, many, many years. So welcome, Dave. And Dave has asked me to pass these around while he's talking.
So I have to respond to that and saying that when as director of the African Center at MSU, I was looking for someone to head the outreach program to take Africa into schools, colleges, community colleges, and the like. We put out an open call and we got this application from this young guy, John Metzler. So he said in his resume that he actually had taken sociology graduate courses. So having been a member of the faculty at Sociology at Wisconsin, I called up the chair, who I knew very well, and I said, what about this guy, John Metzler? So he's a graduate from the College of Education, not sociology. And Russ Middleton, the chair, said to me, Dave, I almost hate to say this, but John Metzler is the brightest sociology graduate student I've had in years. And it turned out as well because John has become the doyen, the dean of the outreach programs of all the Title VI centers in Africa across the country. So we've had a lovely time together. I'm a replacement speaker for you tonight because we hope to have Terry Taylor, who Luna gave an award to, about the year before last, I think, for her having gone to Malawi for 35 years, for 6 months every single year to study what can we do about malaria in African children. We seldom see that kind of commitment. But anyway, Terry, however, just got elected president of one of the major medical associations because of her accomplishments, and suddenly had to leave it. I mean, he could not join us. We also hope to have the head of the Institute of Global Health at MSU, Rebecca Mallon, who's worked for years on a series of diseases in the Republic of the Congo. And she too got called away this week and left yesterday to be out of town. So I'm not a medical specialist, I'm a sociologist, but I was pre-med and got admitted to 2 medical schools, but never went because I had a chance to go off to Africa. And I fell in love with Africa and didn't go back to the medical schools who said they'd hold my position for me. So, you think about what alternatives might have been. But I'm here partly because, as Alan has talked to us about, because of PEPFAR and HIV in Africa, because I will tell you, I believe the American government presently is murdering Africans. And what brought that especially was how intentional it was when the USAID program shipped to East and Southern Africa loads of retrovirals in the PEPFAR program to be distributed to people there. The Congress, it was Biden's Congress that had passed the bill, and Biden signed that bill, so that made it an anathema. The drugs were actually delivered to the clinics, the pharmaceutical centers, and the hospitals in East and Southern Africa. And Mr. Trump and Mr. Musk actually put out an executive order that these drugs were not to be used on patients who'd been receiving the retrovirals in those part of Africa. As a result of that, we now have hundreds, we don't even have an estimate of how many, or maybe thousands of children being born from mothers with HIV whose treatment was stopped intentionally because of a political whim. So having grown up in a small town that was besieged by measles and chicken pox and typhoid of all things, and I'd been from disease, I said, I got to pick this up. And this is what we're doing. What I passed out to you is the statement of the beginning of the national campaign to end vaccine apartheid. You'll see they're signed by Justice and Peace Team of Edgewood Church, which is a national campaign that we're going to be carrying on. I'm going to end this afternoon in telling you how you can join in that process and make a contribution to this struggle to end vaccine apartheid you mentioned. Vaccines were always anathema to me. In my McKinley school down in poor southern Illinois, there was always 1 or 2 days a year when we all had to line up out of our class and go down to the gym where it was full of alcohol vapors, nurses in their uniforms, doctors in their jackets with their needles. And it was a hard time. But when I grew up later, I discovered how lucky we were. And have felt that we too have all forgotten how important vaccines were. Can you imagine that the flu virus was only unearthed in 1942 in the middle of World War II, and the Spanish flu wasn't caught in spite of the best efforts of the medical community to develop vaccines for it, with 50 million people worldwide lost to the Spanish flu. And indeed, in the United States even, we lost 675,000 people in the Spanish flu because of the lack of a vaccine, and which is more than all of the losses of American lives in the Korean, World War II, World War I, Vietnam Wars, all put together because we didn't have a vaccine. Interesting study from the Lancet recently says because they believe that vaccines have saved 154 million lives in the last half century. 154 million lives, and about 6 lives every minute. So vaccines are at the core, and I have become so intrigued with them because in doing my research in communities in Zimbabwe, Zambia, South Africa, again and again, the parents of young children and so on who lost so many, both in childbirth and in the preschool years because of the endemic levels of infection, said again and again, more than better education, better roads, better services, more electricity, etc. We want health. We want health. And so vaccines were a miracle to them. And my goodness, we have much less vaccine resistance in Africa than we seem to have developing in this country now. So as a result of that, the medicine in the United States for dealing with Africa is capitalist medicine, which is based upon the profits of the pharmaceutical companies so well. And we can see here what that difference made. The top line here, the red one, is the higher income countries. The green one, the upper middle income, and the lower middle income, and bottom at the bottom, those who got almost nothing for the first 3 or 4 years of the pandemic of the lower income countries. So the shameful end of the story is that just over 5 billion COVID-19 vaccine doses were administered globally, but only 1.6% of the people in low-income countries have received 1 dose. This is shameful inequity, and it's getting worse by the day because of the capitalist policy of pricing medicines and refusing to share patents for their manufacture. The rich nations are offering third booster doses to their citizens, even as 3.5 billion people across the world are waiting for their first dose. It's a level of inequality that you see in almost no other resource in the world, as we see here. And here we see the what that distribution lists, with the white and the almost white areas being those who got so little at all in the process. So going to the next one. So, but there was a moment of help, of hope. May 4th, 2021, Joe Biden said to Catherine Tai, who was our World Trade Organization representative, tell the World Trade Organization and the nations out there that we're on board. We're going to support the giving of patents on a temporary basis to the countries of the world that have the capacity. And to most people's surprise, there are 132 companies in Africa, Asia, and Latin America that are capable of making their own vaccines. 132. Indeed, what country is the biggest producer of vaccines in the world? India. Who would ever guess? And China is right behind them and had the great, and they, in fact, are one of the sources of solving the African problem. Next one. Joe Biden got voted down by Big Pharma. They said in their, you can see this in their website today, waiving commitments to protect intellectual property rights on the COVID vaccine technology. That means our patent rights. Is unnecessary and harmful with medicine supply far exceeding global demand. Don't interfere with our market. Any expansion of the TRIPS waiver would outsource America's manufacturing jobs, weaken our biopharmaceutical leadership, and undercut medical innovation. So, you know, this was great. So who funded the actual development of the vaccines that they are selling? By the way, retail price this last year from Pfizer for the COVID vaccine, $35 a dose. They're talking about this next year raising it to $135 a dose, $135 a dose, which of course prices it out of the market of most of the world. US taxpayers funded 97% of the development cost of COVID vaccine. And it's related in Myrna vaccines with the US government with our tax dollars putting in more than $30 billion of the development cost and only a small amount from the actual companies that then claim the patent rights. And sadly, we've even learned that the US government had legal rights to claim the productions of the vaccine in order to disseminate them in the global system. But the US government under Biden, and certainly not under Trump and Musk and company, did not exercise that right, but left all of the profits in the hands of big pharma. And so not surprising, big pharma has a lot of interest and they can use some more money because they're spending $500 million a year for lobbying Congress alone. $500 million a year. By the way, more than the entire lobbying budget of the military industrial complex of Lockheed and Boeing and all the rest. And with that, they have 1,800 registered lobbyists chasing Congress and the administration to ensure that their patent rights don't get interfered with and their rights to profits. One estimate is that there have been at least 5 and maybe 9 new billionaires among the CEOs of the pharmaceutical companies in the world as a result of the COVID pandemic. Billionaires. And most all the CEOs of the pharmaceutical companies had annual salaries exceeding 20 million a year, plus the stock options. And so they mustn't give away their patents because they'll hurt the American worker, so they say. So, but it doesn't have to be that way. Well, I'll tell you, amazing positive story here. We had a professor in veterinary science at MSU named Charles Mackenzie. Charles fell in love with Africa and started working with Tanzanians who asked him to do a survey of how much lymphatic filariasis, which we know as elephantiasis, and how much onchocerciasis, which we know as river blindness, was in Tanzania. They said, we know we got quite a bit in the lowlands near the coast, but we think it may be more widespread. He even found both diseases in the highlands of Tanzania, not just in the swamps and so on. So Charles Mackenzie had a vision. So in the 1980s, he went to go visit the Merck company. Merck makes an interesting pharmaceutical called Mectizan or ivermectin. Any of you using it? President Trump wanted you to use it for COVID, right? The ivermectin, that was the secret thing that he learned. But what is it? Ivermectin Mectizan is the favorite American, Canadian, and even increasingly in Africa drug for treating heartworm in dogs. So if you have a pet and you're giving them whatever the name is, it's probably an ivermectin product. And they were making so much money on that Merck decided that they would share their Mectizan, which is the same drug to treat elephantiasis and onchocerciasis in Africa. So they started a program which was giving out as many of the Mectizan doses of 3 milligrams apiece. They have given 13 billion 3 milligram tablets, which is the treatment, at a value of about $5 billion. 600 million people annually worldwide are getting Merck's treatment to some after the disease has been conquered. And in addition to that, unusually, Merck in addition gave $1 million to help fund the distribution of these drugs in Africa, which most does not happen with most even USAID. So as a result of that, we're on the verge of wiping out river blindness like in Africa, except of course the US money is being taken away from that. So from that, let's go to the next one, Watson. What we're saying, in this campaign, which was started on last Tuesday, World International Health Day, by the way, is to avoid vaccine apartheid. The core issue is to give the copy to reproduce vaccines themselves in their own factories with US assistance and so on. But we are actually a long way from getting there. Let's actually, this is the kind of the history of the development of the closing down of support. So let's go to the next one. Cut time short here. So in addition to that, now we are suddenly hit with Trump and Musk's decision to cut USAID. And as I said, the PEPFAR program was one of the reasons that the failure to distribute the drugs that were out there, which got me interested in here. But there was a good piece of news in that with the cuts in the PEPFAR program, two Republican senators, Lisa Murkowski from Alaska and Susan Collins from Maine, got together, went to the House and said, we don't know how they made the argument, but they made a successful argument. So that Trump actually gave the nod to Rubio, our Secretary of State, who by the way is wanting us to attack Cuba, one of the other sources of tropical health assistance. And Rubio processed that in USAID and gave back PEPFAR money that Trump had on his rescission list for his multi-billion-dollar USAID cuts program. And so Rubio enacted this, except I've just discovered recently, doing some digging research with AI, that the annual budget for PEPFAR to treat the people that were receiving it before the USAID cuts was about 4.6 billion. And that Rubio, having said the nod from the White House to replace the PEPFAR funds, put half of the funds back, not all of them. So about half the people in Africa are going to be getting the vaccines, the retrovirals, and so on. And there's been a series of cuts in all sorts of areas of treatment of various diseases, and especially the vaccines. So for instance, UNICEF, which has had a wonderful history of treating preschool kids for the basic mumps, measles, diphtheria, typhoid, and treating about a third of the children of the world every year, and being therefore designated by the World Health Organization as the main bargainer to get prices lower for COVID vaccines for the poorer nations of the world. And UNICEF is having to cut back drastically there. So we're suddenly developing a population across America of zero vaccines, people who have never, ever had a vaccine of any kind. So what's the cost of all this? 10 million new cases of malaria is estimated. In Sudan, 5 million have lost access to food aid and now suffer malnutrition and famine. Matter of fact, the World Food Program has not been successful in getting a lot of private donations for the food programs. So the head of the World Food Program told us recently, we are now having to take food away from the hungry and those caught in famine to feed the starving. So it's just a sidebar on this. 7 nations are now going to lose all their humanitarian funds: Burkina, Cameroon, Niger, Somalia, and Zimbabwe. And because they, like South Africa, are on US bad list. And interestingly, by the way, is how mean this all can be. I have talked to some scientists at George Washington University recently who had African health diseases on their research list and lost all of it with the Trump cuts of USAID, who now are getting called to say, oh, by the way, we'll get you back half of the funds that you had with one agreement. You won't have any dealings with South Africa. South Africa is on the bad list because, you know, they introduced the charges they get for war crimes against Israel in the World Court of Justice. And so they're cooperating with South Africa, even though they had more technical capacity to develop vaccines if they have the patent rights than any other country in Africa. And study from the Jubilee organization says already there's 13,000 kids and adults dead in Uganda from the programs that have been cut. And all of this is called Trump's new America First health program for Africa. It's actually calls it that, the America First program. And they have these MOUs that they're going to every African government across the country and saying, okay, sign the agreement that here, and you agree to give us favored access to all your rare minerals. You also agree to provide us with all your data on use of vaccines and treatment of diseases, and we will give you money. The money they're getting back is about half of what they got in before 2025, but that's the deal they're being offered. And sadly, 27 of the African countries are so poor that even the pennies that Trump and company are willing to give them back is worth giving up things that they shouldn't. Another dozen of the countries have actually organized and to resist all of this cutting of their programs. And we will, so we're in tough, because some of us in Washington want to ask the Africans not to get into Trump, because we suspect he wants all the data on the vaccines and the treatment uses in order to give it to Pfizer and Moderna and J&J for their, so they can catch diseases ahead of time. You know, the Aurora virus of COVID, which changed the vaccine mixture in this country and saved us from a new wave of the disease, was actually discovered in South Africa, who then shared the data with the US companies, who then quickly ran into their labs and got the boosters up to par on that. So the what can we do? Well, it's basically in the paper that I've given you there, which is the call for ending vaccine apartheid. That was a campaign that started last Tuesday. First of all, is to express our absolute outrage at Big Pharma's exorbitant profits and salaries, while the poor world suffers preventable disease and death. Secondly, to condition all public funding for vaccine research on guarantees of equitable access and pricing for resultant medicines and vaccines for all countries, including those in Africa, recognizing the threats posed by chronically weak African healthcare systems as they face HIV, Ebola, Mpox, cholera, and other epidemics. We also want to demand ensuring transparency, equitable representation, and full, unrestricted engagement of civil society actors, particularly from impacted communities in the United States and Africa, and all of these bilateral MOUs, to restore global health funding, including in full support for routine vaccines, and with the sharing of the facilities, the technology, and especially the patents. Then to actively support African manufacturing of vaccines and medicines through technology transfer and partnerships, including through the World Health Organization, from whom you all know, I'm sure we have withdrawn our president's order. And finally, to use the flexibilities of the TRIPS agreements and waivers, which say that there is a technical way that countries in suffering an epidemic can actually demand a compulsory license freeing up so that they can produce their own vaccines. So we want to, even though that has fallen by the wayside in the attacks of Big Pharma on the World Trade Organization suggestion, and to support partnerships across US and private sector institutions, basically to encourage universities and provide funding for them to build partnerships with African universities and to share their technology and their expertise. Generally, ending vaccine apartheid and ensuring ethical health partnerships are essential not only for effective pandemic preparedness, but for upholding justice and global stability. mobilized for a strenuous and costly and long-term struggle to fight for the interest of the poor of the world, for access to health, vaccines, medicines, and well-being at reasonable cost. So if you're interested to stay on the list, keep abreast of what's being done nationally about this by Equity, Justice and Peace and all the other organizations like American Friends Service Committee, United Methodist and others. I have a petition over here for you to sign up if you are interested. So with that, I will say, we're just at the beginning, and we know this is not an easy fight. It's going to be a long fight. We're up against 1,800 lobbyists in Washington, and they're 500 million a year, not including the private gifts that they get for the reelection of members of Congress and the Senate. It's going to be a long struggle, so we'll be back, and we hope that you can join us in this effort to right a horrible, horrible period of murdering of African people by denying them access to relatively cheap solutions.
Oh, thanks, that. Okay, we have some time for some questions and comments. Oh, did you have any questions from last time on the chat? I just saw that.
No, I did ask them, but I don't think anyone had a question. Yeah, I can ask them again before this session. Should be on.
Any questions, comments?
I got just a comment. I just really appreciate Dave's presentation here and a lot of work that he put in. I just want to thank you, Dave, for your presentation and the work that you put into it. And yeah, I'll try to act on this, and the actions make me angry. And hopefully other people get angry enough that it translates into action. But thank you for the presentation.
It's a tough one because, it's not an issue that's present and known to many people.
Yeah.
And so that's why we think the fight's going to be a long one.
Yeah. But I should I won't. But I have one more thing. I think also would just like to see people encourage our government to rejoin WHO. There's no good reason for us not to be a part of that, and it does so much good in the world. And it's just a real pity that we pulled out of it. And I think that should be an area of advocacy. Thank you.
Was just a quick comment that the shocking piece here is the 97% of all the costs for development of COVID was provided by the government, yet no benefit back and no sharing. And I think that's the most persuasive part of all of this. It's extraordinary.
Yeah.
And the government is us. Have fun.
And a lot of that 97%, I'm sure, comes through funding through universities that did the basic research for.
That's right, and research institutes and
Yeah.
the big 97% from the National
Institutes of Health.
Department of the DPI, any rate, and NSF, and even the US military put funding into tax dollar funding into dealing because they were losing a lot of people to COVID and lack of vaccines.
That's a question that there's some comment.
No, that was me asking.
Oh, that was you asking. That should be the new one. Okay.
Well, Robert has a question or comment.
I know that's. Since we're kind of on a little Wisconsin theme here, I just noticed that the governor of Wisconsin just, an executive order for the state to join the World Health Organization Global Outbreak Network. So perhaps that's something that we can work on here in Michigan.
Yeah.
To encourage our government to
The
reconnect.
Democratic governor of California was the first one to do this. And so California is part of the emergency monitoring network now. And big surprise, jumping on board immediately was the governor of Illinois, Governor Pritzker, who is somebody probably a competitor. So that's fascinating. I didn't know I've actually put this forward as something we ought to put on our list. That gives people around the country something very direct to lobby on, get their governor to join WHO along with now 3 other in the union. There is a governor's coalition that the California governor has put together, which is trying to lobby for the same thing. Isn't it? I think you're right. It's as concrete a vote as we could do for WHO in a very direct way.
Raises awareness if nothing else within your own state. Maybe I also want to mention that I had Russ Middleton as an undergraduate. Okay, I just want to say that, yes. I did.
Okay, did you want to say something about membership?
Again, quick, yeah. As the membership chair, I'm just gonna say, if there's anyone here with us tonight here on Zoom that's not already a member of the UN, please consider joining. It makes a statement about our support of UN as well as support for the local chapter that puts on programs like this. And you can go to gluna.org and choose join. Or we have, if you're in the room, forms and QR code for information. Half the membership fee goes to the national and half of it goes to our local organization. Thanks.
Parents, can I just say one quick word? If any of you would like to join in by trying to get people in your network to sign on as well, I have copies of this petition here where you can sign on, and then ensures that you'll get updates via email on the campaigns. So if you'd like one of these, please.
And for next month, May 13th, probably in this very room, certainly here at the church, will be our program focusing on refugee issues. We've got an interesting panel coming up. We will have a representative from UNHCR from Washington to talk about refugee issues on a global basis. And then we will have Kwach Cole coming from the Refugee Services and Catholic Charities to talk about what the situation is like here in the greater Lansing area in terms of who is coming, how many are here, what their needs are, and so forth. And then one of our own board members, Banjar Musa, will talk about the refugee experience as a lived experience as he is a refugee. So this should be a fascinating program. And we will get, as soon as we get a title out of our speakers, we will get this posted.
Thank you. And as always, a great thank you to Tossin for his skills and his willingness to thank you. And also behind the scenes to Samantha Dillon. We wouldn't be able to do this without you.
She was on earlier.
Okay,
Yeah.
yeah. All right.
She is.
Oh,
And one more thank you for David, Dr. David.
yes, yes. Here. And for all of you for coming out. Thank you. And for our youngest member here for participating actively. Thank you.